afternoon, everyone, and welcome to a launch event by International Diabetes Federation, IDF Europe, supported by Lilly Diabetes with Euractiv as your media partner. Now, today we're going to be discussing type 2 diabetes, a preventable catastrophe. Now, first things first, as always, to everyone who is here and everyone who is joining us online, get involved, put in your comments and your questions into our Slido chat page. Now, you should be seeing it on your screen now. There is also a QR code that you can scan to also send those questions and comments into us. And if you are going to be on your socials and tweeting about this hopefully amazing event, and where we will discuss a lot of important things, use the hashtag T2Diabetes. Okay, so I hope that's really clear, and please do get involved. Okay, well, I think the title of this launch event pretty much says everything about what we're going to be discussing today. Diabetes, for anyone who doesn't know, is a chronic condition where the body can't make or make enough insulin. Now, there are, of course, three types. You've got type 1, type 2, and gestational diabetes. And today we're going to be discussing type 2 diabetes. Stats tell us that 61 million people live with type 2 diabetes, and that accounts for about 90 to 95% of the total number of people who are living with diabetes. Now, with things like early diagnosis, access to treatment, leading a healthy lifestyle, so that's your diet or your fitness, this is a chronic condition that can be managed well. But without it, an individual, their support structure, and the healthcare system itself can get overwhelmed. Now, stats tell us that in 2021, 6.7 million people died with diabetes-related complications. 90% of those deaths were related to type 2 diabetes. So the question is actually quite obvious. Is acting early the game changer? Now, this might seem a very obvious question, but if it was, why are the stats so high? Well, that's something that we're going to be asking the experts. But before I introduce you to all of these lovely panelists, first, I welcome to the floor Nebojša Lalić, who's IDF Europe's regional chair. Please go ahead, sir. Round of applause, perhaps.
Thank you very much. Welcome. I'm a little bit now split between the panelists and the audience and the people joining remotely. But anyway, welcome all of you. Thank you very much for the panelists and thanks to all of you for your interest. If I just can take what I forgot. My duty, of course, is just to remind you on what is International Diabetes Federation Europe. It is a European chapter of the International Diabetes Federation that encounters, believe it or not, 73 national diabetes organizations in 46 countries in Europe, and trying to put together and change the course of diabetes, of people living with diabetes, and with the help of healthcare professionals. We have our vision. And the vision is to improve the lives of people with diabetes and those at risk. We have our mission. We would like to be the voice of the people living with diabetes, but not in order to place the complaints, but also to arrange and engage with all stakeholders in creating a person-centered diabetes ecosystem. And we are not selfish. So that should be within an informed and health-promoting environment. So we have our priority objectives to reduce diabetes prevalence, to improve people with diabetes access to care, health outcomes and quality of life, and increase the voice of people with diabetes. So in that case, we embarked into this what you are going to hear today. And because we consider diabetes as a whole, and you see this graph from 2011 to 2030, how the number of people in diabetes would increase despite all our miracles of technology and the rest. And this is, of course, a projection. This doesn't have to happen, and I hope it's not going to happen that way. But anyway, type 2 diabetes within it, and that is what we're speaking about, is a catastrophe. Because, as you heard, more than half of people with type 2 diabetes, and people with type 2 diabetes make 90% of diabetes, the whole of diabetes. So more than half of those will die prematurely. And this is one aspect which is very much worrisome, and there is another one. And in 2021, the costs of treatment related to diabetes was about 176 billion. In other words, 75 of which is related to healthcare costs to treat, otherwise preventable complications. Not to mention that type 2 diabetes itself is preventable. If not completely preventable, then it is possible to delay it. That's why we embarked into this policy paper, which is entitled Type 2 Diabetes, a Preventable Catastrophe, as an urgent call for action to redesign our healthcare system across Europe, and to remove the barriers that are preventing the effective management of type 2 diabetes, which means more than everything else, the prevention. So I will then give floor to the panelists.
Okay, but before you go, I do have a quick question on what you just spoke about there. So you were saying there, the number of people obviously with diabetes is only going to increase. Now, you've got this call to action, which is it's your paper that basically says this is the perfect scenario. These are all the conditions that need to be met in order to improve the scenario for people living with diabetes. But, you know, in this ideal scenario, this perhaps can't, the ideal scenario perhaps can't happen. So what is perhaps the one major factor that needs to change in order to change the circumstances for people living with diabetes and then to bring those numbers down?
If I should say just one thing, that thing would be very, like an umbrella of all others, and that is a rearrangement of the healthcare system, which would, in a structured way, put in place the prevention of type 2 diabetes and prevention of its complications, because this is nowadays the part of type 2 diabetes management, but not the part that is focused by almost any, with some exceptions, but almost any healthcare system in Europe. We would like to make it now put it on the stage, and being the first of our intentions, and then everything else would be just related to that.
Okay, well, let's hope that does happen then. Thank you so much, Professor.
Thank you.
Thank you. Please go take your seat then. Lovely. Thank you. Okay, so time to introduce all of the panelists. Next to me, we have Eric Wesson. He is someone who is living with type 2 diabetes, and he's going to tell us a little bit in detail a little bit later about his journey. We also have MEP Front Bogovic from the MEP Interest Group on Diabetes, MEPs Mobilising for Diabetes. I understand that you also did have a diagnosis of type 2 diabetes, but I've been told that you've been able to reverse this chronic condition. Again, something that we will discuss later. We also have Professor Kamlesh Kunti, who is a professor of primary care diabetes and vascular medicine at the University of Leicester and Leicester General Hospital, of course, in the UK. It's another Brit on the panel. Woohoo. We also have Professor Tadej Batalino, from the head of the Department of Pediatric and Adolescent Endocrinology at the University Medical Center in Ljubljana in Slovenia. Ljubljana, sorry. And finally, we have Maurizio Guidi, who's the chair of the European Federation of Pharmaceutical Industries and Association Diabetes Platform. Okay, so welcome to all of you. I apologize for mispronouncing the Slovenian Medical Centre's name. First of all, let me start. I'll let you all introduce yourselves to everyone here in the room and also our audience online. And first of all, I'll start with Eric.
Thank you. Erik Wersom, living with type 2 diabetes for 25 years. 25 years ago, I went to my physician because I had some itching stains in my face. And he said, well, let's check your sugar levels. And the conclusion was, you have type 2 diabetes. So in about 5 minutes, he explained me what diabetes was and sent me home with oral medication. And I started the 3 worst years of my life because that medication really made me sick. And after 3 years building up the medication, he said, well, I have not so good news for you. You need to switch to insulin. Wow, that was a relief for me. So I was sent home with insulin, had to find out how to inject myself and no support at all. And then a period started with guidance from practice nurses and physicians in which they tried to use a protocol to get control of my life. And what I missed was looking at who I was and trying to let me fit my diabetes into my life. So it was very difficult to me because I followed as much the protocol as I could, but successes weren't celebrated, and finally I said, I'm quitting, I'm just doing it myself. And in those days we only had the finger pricks, so it was a little bit difficult to get a good view on what was happening in my body. And that changed when I was able to use sensors. And then I could see I'm currently at this value, but I'm moving that way, that direction, and I need to do something or I don't need to do anything. And that really helped me. The individual approach was something I really missed, and I had to change a lot of things in my life, but in a way they fitted my life and I could integrate the diabetes into my life. And fortunately at this time I'm managing my diabetes the way I would like to manage it. I'm in control. And of course, sometimes it goes wrong and sometimes it goes better. It's just a fact of life, living with type 2 diabetes.
Okay, thank you very much for sharing that, and we'll get more details from you about your health situation. Next, over to MEP Bogovic.
Yeah, good afternoon to everybody. As you said, I'm from Slovenia. And first time I heard about diabetes too from one old lady in my neighborhood when I was a child. And she lived with diabetes, I don't know, 60, 70 years. And I followed her because she spoke a lot about this disease. Later, it was closer to me. It was in my family. My mother had diagnosed for diabetes 2 type when she was little less than 50. She lived with this disease, I don't know, 35 years. Last year she died in 85. So she lived with this, and I followed this. Then my brother at the age 50 also got diagnosed, and I was careful about this because I heard that you must take care about this. And last year I checked my level of sugar many years, and last year in autumn when I visited a doctor in the European Parliament and checked control of health, he recognized that this is a little bit over the level. It was 6.6 in period of 6 weeks, I think, is measuring. And he suggested me to start to take medicines, and I listened to him. And also we spoke more about this disease and what was that's normal. What he recommended to me to lose some weight. I listened to him. I decided what is not easy in Belgium, no beer, and also
Steak?
sorry, no sweets. It's okay. It's okay. Less wine for Slovenian, not no wine, less wine, and more activities. And yes, I lost close to 10 kilos, and my additional plan is another 5 kilo in half a year, and half a year it was 10 plan, and another half. Another 5, and when I made the control, I think now 2 months ago, the level of sugar was normal, but I use this metformin twice a day, metformin 500 milligrams 5 a day. So as I said, also in the European Parliament, we had last year, few weeks after my diagnosis, we had a debate and we accept this resolution, and it's clear, and I think goes in right direction. And if I may say, I think that if I observe the system, Dr. Butolino know much better about the Slovenian system and also European health systems. During the COVID crisis, we forgot a little bit on other diseases, and I think that after COVID crisis, we have in our country more and more problem in health system with lack of people and also lack of money. So I think that it's very important that we speak about such a disease like diabetes, which is possible to prevent or to slow down the speed of illness. So that's my pleasure that I'm invited here and I have a possibility to speak about this.
Definitely. Okay, Professor Kamlish.
Hello, everyone. Kamlish Kunti, I'm a general practitioner and I work in the area of research in diabetes. Today we're talking about a catastrophe. There are a couple of catastrophes. One is that we can prevent this tsunami of diabetes that's occurring by prevention measures. But today we're talking about people who have type 2 diabetes and the catastrophe facing them. We have excellent evidence base and great trials showing that we can prevent diabetes, but once people get diabetes, we can manage it so that people with diabetes do not get the complications. And the complications, as you all know, are things such as eye disease, kidney disease, feet disease, and heart disease and strokes. All of these are preventable. And we know that about 50% or more of people with diabetes will die of those complications. Often it's cardiovascular complications. But we have such good evidence that we don't need to get to that level. And this is doing simple things as in managing blood pressure, managing glucose, managing people's cholesterol levels, empowering people so that they can manage their condition well. You had a really nice example here just now. Trying to reduce obesity levels, stopping people smoking or helping them stop smoking. These are really simple things, and we don't need to use expensive drugs to do many of these things. And all of these together, we can reduce the risk of complications dramatically. So if you look at some of the data out there, people with diabetes, type 2 diabetes, lose anything from 6 to 8 years of their life compared to someone who doesn't have diabetes because of these complications. And there is good data out there showing that if we do all these things well, people can gain 6 to 8 years of life. So we really do not need to be at this meeting today if we did all of that correctly.
Okay, well said. Professor Tete, over to you next.
Yeah, thank you very much. Also a pleasure to be here with you. What I would perhaps like to stress is that all current guidelines introduce disease-modifying medications at a quite late stage. So if you have, cardiac involvement, okay, then this drug is good for you. If you have kidney trouble, then, the other is also available to you. But what perhaps should be the focus is that people never get there. And there is also ample evidence that you can, by using disease-modifying medications, prevent all these conditions. So my view is that we have to change professional guidelines in a way to identify very early those at risk, and of course by early introduction of disease-modifying medications, change the course of complications. So number one is early identification, and I really like our co-panelists today mentioned CGM, so continuous glucose monitoring. This is a tool that really shows what happens with glucose over a larger period of time, and also, of course, predict possible complications. And the second then, that as soon as these people with an elevated risk are identified, immediately the disease-modifying medications are available and also accessible to them. So all barriers of different kinds that were mentioned previously are, particularly in our European landscape, removed. So this is perhaps the focus I would like to propose to you. So very early and precise identification with perhaps continuous glucose monitoring, and then immediate action upon it in those with an identified elevated risk.
Okay, thank you so much. And then lastly to Maurizio.
Let me start highlighting one thing that to me is, and to us should be dramatic, that in the few minutes that I'm speaking, 6 Europeans will die for diabetes and its complication. And I would like to highlight that should be very personal, because in these 6, there is my father-in-law, Piero, there is someone else's sister or parent. And what is dramatic is that, as highlighted by experts, science is telling us how to prevent this death. It's not only death, it's about also quality of life. Diabetes is the second highest cause for loss of quality of life. It has been estimated that 2.6 years of productive life is going to be lost for people with diabetes versus people without diabetes. So it's a very, very important point that healthcare system should manage, and should manage different, because as highlighted by Professor Lalic, there is 176 billion euros for diabetes, and up to 75 are also preventable costs. So science is telling us that we can save lives and also save money. As just if you can give me one more minutes, I would like to highlight that building and bridging to Professor Battellino, that as a FPA diabetes platform, we have working on 2 surveys that I would like briefly to share. One is called weight indicators, and we look at the 17 molecules that has been available from 2014 to 2020. No state has all the 17 molecules available, with the variances from 3 months of delay to 4 years of delay. So obviously, the equipment to healthcare professional has been dramatically reduced by having a limited access to this new molecule. And the other survey is something that we have developed in collaboration with PricewaterhouseCoopers, and we look how easy for a healthcare professional, well-educated, well-motivated, as well as a very well-motivated person with diabetes to follow the guidelines. And again, the basic result was that it's almost impossible, because there are policy barrier, country level, that are essentially doesn't enable to follow the latest science indication. That's something that probably we should consider to be addressed.
Okay, well, let me ask you a follow-up question to what you're talking about there. If this is the second highest cause of loss of life, what's got us to this point that it is the second highest cause of loss of life? Is it just a case of something that has spiraled out of control? If you're saying the science is there, the data is there, you've got partners working on concept papers together, looking at this disease, why is does it cause so much death, and why hasn't this been addressed?
We believe that our healthcare system are more equipped to manage acute care rather than chronic condition. And that's one of the issue of this. But as has been highlighted by experts, there is a few steps that we need to make in order to make a sustainable change. Early diagnosis is one. Early intensification of treatment is another one. And then there are, as highlighted by European Diabetes Forum, 3 key enablers at the healthcare system, like data registry and outcome, like the better integration of primary and secondary care, as well as digitalization, that can really dramatically change if the overall mindset change is established. But definitely we consider a cost, inevitable cost. Healthcare, while it's also an investment, as well as also for some treatment and the pharmaceutical, it should be considered rather than a cost, an investment for preventing the complication that are driving so much the skyrocketing cost of the total healthcare.
Okay, so Professor Kamlish, to follow up on that then, what do you think the crux of the problem is? Is it a case that, you know, the healthcare system can't deal with chronic conditions?
I think that there's a number of barriers. One is the person with diabetes level, healthcare professional level, and system levels. System level is access to the products that we have sometimes. That's a big barrier in many of the countries. Healthcare professional levels, they have too many conditions to manage. So a person with diabetes doesn't normally have diabetes, as we've said, they have other conditions. So someone aged less than 65, they will have diabetes and 2 other conditions. Aged over 65, they will die with diabetes and 5 other conditions. There's a lot to deal with there for that person. And diabetes can be quite silent. High blood pressure, high glucose, high cholesterol doesn't give you symptoms. A person with diabetes may have depression, they may have lung disease, which is giving them symptoms. They want to deal with the symptomatic diseases first. So they may not pay as much attention, but that can be reversed by giving proper education programs for people with diabetes and empowering people with diabetes to manage and informing about the risks. And then the big problem with healthcare professionals, again, the system at the moment, as you mentioned, after COVID is very difficult. We're having great difficulty recruiting people, retaining people. There's still a lot of people are not working because of effects of COVID, either direct or indirect. System, there's been a backlog, so we're trying to bring everyone through 2 years of backlog. Even before the pandemic, we had issues about management because...
But also there was years of austerity, so,
Exactly.
you know, so many countries were cutting their, you know, their budgets, their staff, everything.
We just don't have the workforce. I said the things we need to do are simple: getting blood pressure managed, getting cholesterol managed, getting blood sugars managed. But the system isn't geared to give that much time to the healthcare professionals to manage those.
But Eric, has a system ever been geared then? Because you're someone who, you know, was unfortunately got this disease over 25 years ago. So, I mean, from your experience hasn't been a good one. We've just heard, you know, a few sort of excerpts from your story. You talked about bad treatment, no support, you went alone. So, you know, we can blame things like austerity, we can blame things like pandemic, we can look at the situation now of the healthcare system, you know, across member states. But 25 years ago, was it worse?
It was worse. If I look back 25 years, then a GP, he knew a little bit about diabetes. And then the practice nurses started and they got educated. But in the beginning, you had many different types of practice nurses with different levels of education. And I think that has been improving over the past years. And at that time, I had to educate my practice nurse instead of the other way around, because I found out more information than that he was aware of. And the other thing was that in those times, they were not aware of the personal impact or your personal life. I was treated as a patient and not as a person. And nowadays, I think practice nurse should be more like a social worker, looking at who you are, how your life is, and what can you do in your life to incorporate your condition into that life. So I have seen it improving. And the other thing is, what you said, you don't feel anything if you get diabetes. There are almost no symptoms. And in my environment, I see that many people with type 2 diabetes, they think, well, I have type 2 diabetes, but I don't feel anything, so why bother? And we don't have a network, because if you have type 2 diabetes, you are alone. You are focused on yourself. You're not aware of other people in most cases, and that could also improve.
Why are you alone,
awareness.
though? Because I think for the audience as well, it'd be important to understand that.
You only see your GP or your practice nurse, and you don't meet anyone else with type 2 diabetes unless you go and find groups, focus groups, and people that also have type 2 diabetes. But you just live your life. Why bothering about diabetes? You don't feel anything. Many people do it that way, and they don't get the right treatment and the right support. They are not educated well enough to be able to manage their condition.
So in an ideal scenario then, I mean, well, perhaps not an ideal scenario, but what do you wish could have been done better for you? And what is being done better now that you can see, perhaps?
First of all, holistic approach, not only looking from a treatment based on a protocol. More awareness about who you are, that's part of the holistic approach. And maybe creating focus groups with people that already have type 2 diabetes and that know how to deal with it and learn from each other, because everyone is different. I once was in a group with people with type 1 and type 2 diabetes, and I thought, well, the type 1 can't learn from me, and I shared experiences, and they said, wow, I can, what you do, try in my life, and you learn from each other and you find out what works for you.
Okay.
And that could really help.
Amy Pipokovic, your sort of journey in this has been perhaps a little bit easier because you said your mother and your brother also got this disease. Did that perhaps help you in a way, or to understand this better?
Yes, for sure. This helped me, and that's the reason why I followed my level of sugar also before, when it was close under the level, and then I recognized. But I want to add what the Dutch colleague said and compare these practices in my country, in Slovenia. I was 13 years mayor in my country, and I had many events and many meetings with people who represent diabetes 2 type patient. They are organized in the clubs. They have meetings. As mayors, we supported their meetings and the work of these clubs. So I can say for my country, and this is not only when I was mayor, as I said, I was a child when this neighbor lady explained me, and I know that it was 20, 30 years ago, they were organized. So it's a little surprise for me that in Netherlands you don't have such a type. Perhaps Professor Bottolino can say more about this. He's close to them also. So I can say that for me it was easier, as I said, and I explained that we have this disease in family, so I take care about this and follow this. Also, I follow all the time my blood pressure and other things which are connected with this. And this public awareness about diabetes in Slovenia, as I think, it's much better than I heard before. So I think this is very important that we know more about this and these simple things which help us to prevent the consequences of diseases. So
Professor Dede, I mean, perhaps you can add in there about this public awareness in your country. I mean, what is done to make people more aware?
Number one, at first I agree, it's crucial. So I agree many people are alone with this disease and shouldn't be. So are we better in Slovenia? It's hard to say. You know, everybody wants to believe so, but then, you know, I know many people that are alone with type 2 diabetes in Slovenia as well, despite the best efforts. So what was emphasized by you actually, I think is extremely important. So connect with other people and discuss what's happening is of major help. What I also heard from the 25-year-old story is, and I think this is crucial for today, that it used to be a drug that make our colleagues sick, and then it was insulin. And this has changed enormously. This is probably the biggest change in addition to technology that we saw in the field of diabetes, which is that innovative medicines actually are disease modifying. So they are perhaps less offensive, particularly if you want the risk of hypoglycemia, which is a barrier to every therapy in diabetes, is now, with the novel medicines, negligible, so to say. So one of the reasons why this seemed to be neglected is that we didn't have an armory to deal with it properly, and this is extremely frustrating for physicians. We understood that telling people eat less and move more doesn't work, right? And the tools were sparse. This is now different, and we have to acknowledge it, understand it, and incorporate it in our healthcare system. It should be on the primary care level, as Professor Kunti mentioned. It should be within the social networks in a country, but it also should be accessible to people. So not just, you know, on the internet and then you read it's for the rich in California. It should be accessible to people with early diabetes in Europe. And this will change the outcome, and I couldn't agree more. I mean, you know, if you look at the cardiology, which is largely overfunded with all the, you know, rescue therapies, instead of, you know, diverting this money into prevention and, you know, have people at 70 that do not have all these terrible chronic complications, is an investment and is finally money saving. So a public system like we have in our member states probably should acknowledge this and really change the way we deliver care and invest in preventing early on these complications rather than, you know, having sophisticated facilities to manage them when it's too late. And a part of the blame is also with us, with healthcare professionals, because we are a bit hard to change. This is my experience, lifelong experience. I'm not sure what Kamlesh will say about it, but we are a little bit conservative, which is good for very sick people in many ways. But then on the other hand, perhaps we need to change a bit also and, you know, change our guidelines and say, look, I mean, detect and treat. This is now the mantra, and prevent with this. And the last thing is the quality of life. This was also seen, you know, in this 25-year-old story. So it didn't work. So the quality of life, I believe, matters most. We didn't speak about dementia. Unfortunately, type 2 diabetes is highly linked to dementia. Some people say, okay, I don't care if I die earlier. Okay, but most people care not to be demented by the end of their life. So it's another super important.
No one wants to die a horrible
right?
death, essentially, yeah.
You know, so I think it's a super important angle to say people, okay, so it doesn't hurt, okay, you don't feel it, fine, but it is related to outcomes you really don't want to have. So, you know, which is an additional, perhaps, social motivation to really, you know, accept, be concordant with the early intervention, early diagnosis, and early disease-modifying therapies that basically can reverse the course of the disease.
Professor Kamlesh?
Yes, I think we need to have a complete rethink of how we manage people with diabetes. The most cost-effective delivery of healthcare is in primary care, in general practices. And there's been quite a lot of evidence for that. Specialists, we need them when patients have quite severe complications, specialist complications that primary care cannot manage. Primary care also knows everything about that person, not just about their diabetes or heart disease. They know about their social circumstance, they know about their mental health conditions, past history, etc. So the core should be management at primary care. At the moment, we have 10-minute appointments. You can't manage this in a 10-minute appointment.
If that.
Right?
And the UK is quite terrible right
Exactly.
now.
Well, no, it's like that everywhere.
Everywhere, yeah,
Yes,
yeah,
it
no,
is.
for sure, yeah.
So I think we need to have a rethink, and we've talked about the progress that's been made in medications over the last 25 years. It's tremendous, it's enormous, I mean, it's life-changing. But you can't have a general practitioner being good at everything. Your lung disease, your heart disease, your depression, you just can't do that. So what we need to think about is having specialists within a primary care setting. And we don't have enough doctors.
Is it about going back to how we teach,
Yeah, it's from the start
Yeah.
onwards, but the model of care completely needs to change. And we don't need doctors. Obviously, there is a shortage of doctors. We're not going to get that many doctors. But in the UK, there are other examples, Netherlands. You can have well-trained nurses, well-trained pharmacists who can give time to that person with diabetes, who have the knowledge, the skill. They've been empowered to manage at such a high level. And it doesn't have to be diabetes. We need to also start thinking about multimorbidity. A person with diabetes will have, as I said, cardiovascular disease, kidney disease. So you could have a holistic approach of managing a person who has that expertise of a number of conditions, not just one condition.
But where would you start then? Because obviously, I think every citizen, they expect a lot from their GP. We do expect them to have knowledge on everything. We go in for the 10 minutes, we sort of verbal diarrhea everything that is wrong with us. And we expect them to have these magical unicorn solutions from us. But perhaps, how then do you change the system? Instead of us going to the GP, do we go to the practice nurse? Do we is there an avenue for us to go straight to the pharmacist? How do you change the whole system, essentially?
When I say pharmacists, I don't mean pharmacists in the high street pharmacists. I'm talking about pharmacists that are now embedded within primary care and GP practices. So we're employing a lot more pharmacists now because there's a shortage of doctors, and they are extremely empowered. They go and do a diploma in diabetes, diploma in cardiovascular disease, masters in diabetes and cardiovascular disease, and they can manage the complex patients. They also have the prescribing rights, so they can prescribe. The nurses and our pharmacists can prescribe as long as they've gone through the program of safe prescribing. So I think we just need to think very, very differently. Now that we're coming out of the pandemic, that's the only way, in my opinion, that we're going to be able to cope.
Okay, and Professor Maurizio, your thoughts then? How could things be done differently? You've heard from Professor Carmish and his ideas, so what about you? What would you say, how could it be done differently?
Starting from realizing that the current setup of the healthcare system will not bring better result if we don't change. As highlighted by Professor Kunti, definitely we need to make some adjustment, and integration of primary care, secondary care is one key component. But also I would highlight the need of moving from a reactive medicine to a more proactive medicine. Non-communicable disease are impacting 80% of the total budget of European healthcare expenditure, 90% of the death, and diabetes is a key example of non-communicable disease where a lot of cost, but also a lot of death are associated to complication, as been highlighted by experts. And that's why we need to move from just managing the acute phase to a more person-centered system where the complications are managed early on. And these are also great examples from MEP Bogovic of early identification, early treatment, with dramatic change of outcome. On the other side, Eric was highlighting an approach that has been established that is called treatment to fail. You fail one, then you upgrade the therapy, you fail the second time, then you failed another time, and then you upgrade again the approach. But unfortunately, once complications are developed, we cannot reverse that. That's why what has been highlighted by experts is that the science is telling us that we need to make some changes. And with these changes, I'm really optimistic that also the healthcare system can be sustainable. That's
Okay, well, let me then come to the two people that, of course, have this chronic condition. Eric, I'll come to you first. You hear what the other panelists are saying. I mean, what sort of changes would you like to see brought into the system?
Well, some changes that I already see happening, like you already said. Practice nurses get trained far better than they used to be in the beginning. They get more experience in how to deal with the treatment for someone having type 2 diabetes. And they also have more time. It's not 10 minutes, they have 30 minutes, and you can discuss things with them and look at the best way to do that. And the other thing that really helped me, and that I would also like to everyone have, is the CGM. Because I used to do the finger pricks 8 times a day, 10 times a day, until I got sore fingers. But it still didn't help me enough, because I couldn't see what was happening in my body. And with the CGM, I can just see what is happening and manage my diabetes. And at first I had to pay it for myself because it wasn't reimbursed, because I didn't have any complications yet. And fortunately that changed in the Netherlands, and now I can use them. And for me, it gives a lot of rest and a better quality of life. So I think those two things, practice nurses with the proper knowledge and skills, and being able to manage your own blood glucose, that helps.
Okay, so here again, we're hearing this kind of, perfect scenarios, different approaches in different countries. So MP Bogovic then, obviously as a representative of the European Parliament, is there something that can be done on a policy level?
Yeah, for sure. First, what is dramatically is that costs of this disease is higher than annual European Union budget. So if we compare these figures, we see that we speak about big costs. We all know that in health system during the COVID crisis, there are new measures which are related with European Union. Otherwise, European Union is not responsible, or there are not regulative for health system on the national level. So if we exchange these good practices, this is for sure something what we can do. I don't know. We speak a lot about also about digitalization, about e-health, about artificial intelligence, and I don't know. I work in Agri-Regi committee, and my topics are smart villages, and I saw some solutions from Vodafone, for example, for Greece islands, how doctors come and make these fast tests on different diseases, be connected with clinic, and perhaps also for such a diagnosis which are, as you said, quite easy, and it's not necessary that they are made by doctors. Perhaps we come closer to the people and to offer them access first for this diagnosis, because, as you said, you don't know that you are ill, but the process is going on. So if and these suggestions are in this resolution of European Parliament that 80% of people should have this fast access and treatment and other things, and also this things connected with style of life, other things. All these things are mentioned in this resolution. I don't know if that's enough, but for sure that's the first step. And what is interesting, such a resolution is not a resolution where we are divided on left and right, and this is all people speak.
It's always tricky for MEPs to really try to move the needle, because, as you said, health isn't per se an EU competence. They have, you could say, an opinion on it, but it's for the member states. So that in itself, I mean, does it sometimes get frustrating then, as someone who's also suffered from this chronic condition, to not be able to really affect real positive change within the member states?
I'm not sure that on everything we can decide here in Parliament or in European Parliament.
Of course.
There are things which are necessary to be close to the people. And as I understand, especially if we speak, I don't know, about cancer, or also about vaccines against COVID, it was, I think, good that we put money together for research and other things, and also for I don't know, different types of cancer. There is also in this, we go in this direction to make research. But as we said, heard here, here are many things are known. We don't speak about things which are not known, and these things which we know, I think that through exchange of these good practices, if we compare different countries, perhaps we can help that the good practices we will share in all countries, and this different cases, and this is in this resolution that take care about this and also give to the people access to early diagnosis and early treatment. These are, I think, the most important things about diabetes.
Okay, Professor Helmer seems to be nodding quite a lot there. Would you like to add something in there?
No, I think what you mentioned is absolutely correct. It's that we know everything. There is enough evidence here.
Yeah.
We just need to put this into practice. And we've talked about some of the models of care. One of the things that I think, Eric, because you're a person with diabetes, you may not mention this, I think we really need to empower the people with diabetes as well. Because
how do you do that?
well, there's evidence-based education programs out there. For example, we've developed one, Desmond, there's many others as well. We are quick at writing a prescription of an expensive drug to a person with diabetes, but we don't give as much emphasis about an education program. If we put the same amount of emphasis to the person with diabetes, say, this education program is going to help you equally, if not more, than that medication, they're more likely to take it up. And by education program, I don't mean sitting in a clinic in my 10-minute or 15-minute or half-an-hour appointment. We're talking about 6 hours of yearly education programs that people can access, either a face-to-face group education or through
Online
remote
learning
channels.
or something?
Sorry?
Online learning?
Online learning, yes. So there are evidence-based, cost-effective, and they've been evaluated in randomized controlled trials to show they are cost-effective, and they're a fraction of a cost to a monthly prescription of one of the newer therapies.
Gosh. So is that happening now in the UK? Or
Yes, it's available to everyone in the UK, but a lot of people with diabetes are not taking them up because I think the emphasis hasn't been given to say this is as, if not more important than the medication. And that's why, if you think about it, a lot of people take the medications, but after 6 months, a year, we call it non-adherence, they stop or don't take it as they're supposed to be taken on a regular basis.
hold on, why would somebody stop taking the medication? Is it because it's working? The levels
Well,
are
either
normalised?
there's all sorts of reasons. People with diabetes, as I said, they have busy lives, they have lots of other conditions, and it just doesn't happen. So, for example, statins, at 6 months, 50% of people taking statins, which save lives through heart disease. But I think one of the reasons is because they don't have the education regarding the importance of continuing that, or their HbA1c goes down. They think their blood glucose is better now, so they don't need to take the tablets. But we know as soon as you stop the tablets, the glucose will start going up, similar to the blood pressure. But it's quite complex why people stop taking tablets. But if you have the education programs, you can increase adherence to medications.
Okay, Professor Dede, I can see you nodding. You want to add in as well?
Well, perhaps I would like first to say that I do believe artificial intelligence may help. And particularly if we unify primary care electronic medical records, at least in an environment, but hopefully across Europe. So unified primary care electronic medical record is a must. And I think will enormously facilitate whatever people's needs are. And artificial intelligence, as we now all know, actually can help discuss things very efficiently. So it's a tool that I do agree and actually very much support what you said, could help us. And particularly EUDF inside the field of diabetes is going this path and emphasizing the use of intelligent artificial intelligence approaches and clinical decision support systems, not only for healthcare professionals, but also for people with diabetes. And the second thing is that we are happy to import Eric to Slovenia. So the thing is that people with diabetes can help each other quite efficiently, perhaps better than any other healthcare professional. So it is true, in our country we do have this support, it's called peer support. and people with diabetes volunteer actually to help others. And this is particularly important for what we say concordance with therapy, because when when you hear it from a healthcare professional, we say whatever, right? So they may or may not listen. When they hear it from a peer that experienced the same trouble for many years, they are perhaps more likely to take it seriously. So the peer support that was mentioned by Eric, we believe is crucially important, and we really try to build on it considerably inside the society. Do we need cross-border, inside member states collaboration? I think we do. And IDF has now a camp, actually. It's a type 1 camp at the moment, but should become a type 2 camp also, because this is where this, cross-border exchanges of practices and ideas, beliefs, or lifestyles even can happen. So I do believe that this, the importance of peer-to-peer support communication that should be, of course, within regions, but also the trans-regional, is of crucial importance. And, in the end, if I hear that somebody in Spain or Netherlands has the same trouble and does it this way and it works, it's a good news, right? So I perhaps can take it more easily and be more successful.
Okay, brilliant. Well, we talked a lot about technology. Let's come to the costs of it all then. 176 billion euros in 2021. Obviously that's a massive cost, and we've spoken about this, but in order to reverse the trends that we're seeing, the mortality rates, etc., where do you find that extra investment from? And perhaps MP Bogovic, that's a question for you. Where does the extra funding come from for this then?
Where we can get extra funding?
Yeah, where can member states find it from? Where can the funding come from? Where can they find the extra money within perhaps the healthcare system itself? But
reforms doesn't always means find new money. And as we heard, to change the system, to change the approach. I don't know when I thought when we speak about this, in Slovenia, for example, we are very good in firefighters organizations. To organize at their place where people comes together to make these tests or other things, to go to schools, to go to people where people come together and other things. And I think for sure it's always the question of money, but in case of diabetes, I will not start first with additional money, but the changes how we manage this problem today. And I think that we can do with 175 billion a lot, and perhaps that I'm not a specialist in this, but that's my answer on your question. And I usually I complain about this, that always reforms means additional money.
Okay, Marzia?
First of all, let me highlight that out of 176 billion, pharmaceutical is counting around 10%. Okay, so the question is a very good one, and I would like also to suggest to think how to manage these 176 billion better. And let me tell you, at the present time, there is a segregation of budget. So the pharmaceutical budget is separated from the territory budget. And our system sometimes is interesting in some behaviors because we don't have the money to make available some innovation that can really prevent complication. But we have money for dialysis, we have money for all the complication when it's happening. So having a different management of the expenditure and enable the possibility to early on to invest in order to prevent can save money and to reallocate in a way that is more strategic. So that's, for example, one example that we can consider. And FP in the past has been highlighted with a study that diabetes was essentially across Europe managed with the segregation, with this silos budget approach, that for a chronic condition, and I would like to hear also the expert, doesn't seem to be the best solution for ensuring a long-term effective management, for example.
Would you like to say something?
Yeah, I'm not sure we're going to get any additional money, so we need to work with
work with what you've got. Yeah.
And I think this is where we've talked about today, that what we need to do is identify the person with diabetes, so there's a proactive screening of people, and then trying to get them to target really early on. So there's so much good evidence showing if you get your blood pressure target, your lipid target, your glucose targets from the beginning, we get what's called a legacy effect for all of them. So doing something now within the first 5 years, they get benefits 44 years down the line. And there's now data showing up to 44 years down the line. What we're not doing is we're diagnosing and waiting too long to get people onto target. We're waiting anything from 1 to 7 years, despite patients' risk factors being high, that we're not controlling them. We're not putting all the therapies that we have in our armament. And the problem then escalates because they will get the second condition, then the third condition, and then it becomes into a spiral. It's very difficult to manage once they've got to what we call multimorbidity. But we can prevent that multimorbidity just by going very early with all the therapies that we have now.
So we should change from sickness management to health management.
Yeah.
Mm-hmm.
You'd like to go ahead as well? Yeah, please go ahead. Yeah.
Well, you know, there is a JAMA, Journal of American Medical Association publication, and they investigated whether, you know, CGM that was mentioned by Eric as life-changing, and I perfectly agree with this, being considered expensive is perhaps cost-effective, and it was actually money-saving in the first year because the admission rate, acute admission rate, and emergency department visits went down. So Kaiser Permanente, which was the insurance system that published this data, said, no, interestingly enough, the so-called expensive CGM is actually saving our money within the same year. So if you look at this question, I think in Europe the trouble is that the budgets for primary care and hospital care are divided. This is the most difficult budget. And most money goes to hospital care. You know, so I couldn't agree more than in a chronic, non-contagious disease management, this should be one budget. And basically, should we say, look, the longer you can stay on primary care without complications, the happier we are. And this is clearly money saving. It's no question about it. Do we need an initial investment to do so? I think yes. Why? Because we can't say to a person that needs, you know, dialysis or, you know, PCT, you can't get it because we are putting money on primary care. You can't say this, right? So I believe that perhaps an initial investment, not only into medication, into electronic medical records that are unified across the system, so that the person has a follow-up, you know, from the very beginning within the same system, and basically, you know, a longitudinal development of his or her disorders are clearly displayed to the primary care physician. And of course, early intervention with, at the moment, expensive medicines. No other way. So this is an investment. But then, if you're able to show to the society that perhaps within 5 years, as suggested, then the chronic complications start to go down. It's not only eye and heart and what we said, dementia and the brain, it's also amputations. You know, it's saving of productivity within a country. So there are very seriously good reasons to do so. So I do believe that an initial investment is necessary. And I also believe, you know, we are discussing austerity, but, you know, to people outside the European Union seems to be terribly rich.
That's true, yeah.
I do not believe that we have a very serious money issue, particularly not when we are investing in something that will bring back billions of euros, quite obviously. But not only billions of euros, it's the quality of life of these people, if the change of philosophy, how they live. Because this, you know, if you preserve a person in good health, this is changing his or her philosophy, obviously. and also of this family, and perhaps also of the micro-society around. And if these people become more vocal, which is one of the IDF goals, they are more heard, perhaps they can help change us, the philosophy and the society. And this is what we really want. So there is an initial investment, I'm afraid, that is necessary, but that will pay off considerably within a very, very visible future.
Okay. Whilst there, change philosophy and the way in which money is spent. Okay, I'm going to quickly run through a few questions. I think we have about 10 minutes left. So Anne Met asks, well, they're wondering if measuring blood sugar levels is part of an annual check at the GP, as undiagnosed diabetes could give many complications. The undiagnosed cases could perhaps be avoided. Professor Kalmish, that's perhaps a question for you.
I think so. This is about screening for diabetes. So screening for diabetes currently is not systematic in most countries. The UK has a NHS Health Checks program where anyone from the age of 40 to 74 gets 5 yearly checkups if they haven't got diabetes, heart disease, etc. But and that's showing that we are picking up lots of people, and they're going to a prevention program. It's preventing diabetes. So certainly, it seems to be working in the English healthcare system. All the other places are very reactive. So patients get symptoms like Eric did, or they get a heart attack and they're screened for it. So it's not proactively done in many other countries, and I think I agree. There are simple ways of doing it. There are risk scores that you go onto online, just asking simple questions about your age, your family history. If you're at high risk of that, then you go and have a check. If you're low risk, then you don't need to go immediately. You can wait 3 to 5 years.
Okay, but are there any sort of signs or indications that somebody might need to look out for?
Oh, it's the usual. You know, you're passing urine more often. You're thirsty. You're tired. All of those are classic conditions.
Okay, and they shouldn't feel bad to be wasting a doctor's time if they think that they might have a problem. They should go. Okay, Costas says CGMs for type 2 patients will be a great help and eventually will reduce treatment costs, but the healthcare systems in Europe, the majority of them do not reimburse the expense. This is where the focus must be put. Eric, perhaps, I don't know if you want to take this, but this is something you were talking about as well, but not being reimbursed.
That's right. I used not to get it reimbursed because I didn't have enough weight. So I had to gain 70 kilos first before I could use it.
Gosh.
No, but it changed. I paid them for myself for a few years because it really helped me, and I wanted to take action on my own life. I wanted to manage my diabetes. And fortunately, it's reimbursed now in the Netherlands. So it really gives me enough possibilities to manage my blood sugars.
Okay, great.
I couldn't do without it anymore.
No, of course. Issa2 says at-risk individuals need education, this is what we were discussing, access to ongoing support and an adequate environment to engage in health-enhancing behaviours. Healthcare practitioners and systems can contribute by introducing healthcare information technologies to screen for unhealthy behaviours or deliver interventions. I think that pretty much summed up what we're all talking about. Would anyone like to comment on that, or we just nod and go on to the next one? Well, they also asked, the same person has also said, since hypoglycemia is a strong risk factor for diabetes and many adults with pre-diabetes will likely develop diabetes unless lifestyle changes are made, can hypoglycemia be clinically targeted for preventative measures? Professor Tade, perhaps for you?
All in. So whoever this person is, please help us. I think this is the right focus. Yes, glucose is dangerous. So it should be addressed early on, and pre-diabetes is a very good target to be addressed. And particularly, of course, in relation to obesity, which is a terrible trouble that we didn't even start to discuss seriously. Yeah. So thank you very much for this question, and whoever you are, please help us to do so.
The data for it are incredible. You can reduce your risk of developing diabetes from what we call pre-diabetes or intermediate hypoglycemia by 50%, just by going to a lifestyle intervention program.
Okay, and are there apps that also support these programs as well?
There are, yes.
They are apps, but the attrition rate with these apps is terribly high. So I don't believe we found an app that's, that has a long-standing effect. Perhaps the technology is not good enough, perhaps, I don't know. So there are some reasons that at least I don't know, for an app that has a long-term success. The attrition rate is extremely fast, within weeks. So I would say a combination perhaps of this online support and peer support, because people are people and we like to discuss with other people and we tend to believe them what they say. So perhaps a combination of the two.
And Eric, you were saying you don't use apps really, do you?
No, the only app I use is to read my sensor. But I tried many different lifestyle interventions, diets, exercise and alternative therapy. And I found the combination that works for me. And it's especially a low-carb diet and some exercise. That's what's helping for me. And sometimes I look in an app for some data about nutrition facts. But usually I just read the packages and I know if I want to take it or not, if it fits in my schedule.
Okay. MEP Bogovic, any insights on, any apps that, have you used any apps or?
No, just measuring and apps. Okay, I follow how my activities through the days. That's the app which I use in this context.
Okay, perfect. Well, we have a few minutes, so I'll allow all of you just to give some final thoughts, any sort of advice for anyone that's watching. So, Eric, start with you first.
Yeah, thank you. I think we're moving in the right direction. I've seen a lot of changes in the past 25 years, changes I am very happy about, and especially what we are doing here, creating awareness of prevention and especially preventing the effects of the diabetes. I think that's very important.
Okay, go down the lines, Professor Conlish.
Well, we've got enough evidence to tell us what we should be doing. We've had this evidence for 25 years or so, but for various reasons it's not happening. So I think we need to restart thinking, how do we get this evidence into practice?
But a question, can anything actually happen given that, we've seen because of the pandemic?
Yes.
Can change come, or do we have to get past the effects of the pandemic first?
I think, first of all, interesting about the pandemic, we've had 2 years of people not seeing their doctor or their nurse. We may have more people die of the indirect causes of the pandemic than the direct when they got the infection, because they haven't had their risk factors managed. So I think what we need to start thinking about is who's the highest risk people, bringing them in, getting their targets, so that we can prevent the longer term complications. In the medium term, short to medium term, we need to think about new models of care to see how can we manage this population, because at the moment it's unmanageable and we haven't got enough doctors, we haven't got enough consultants. So we need to think about different models of care that we've discussed. Definitely.
MEP Bogovic?
In few sentences, speak a lot about this disease, that we know what it is, diabetes. Then to know where you are risky, is this in family, obesity, other things. Then to ensure early enough diagnosis. And then I think it depends a lot on us also to manage your lifestyle.
Of course. Professor, please go ahead.
Yeah, I think from a physician standpoint, it's really important people have access to, as we discussed, to technologies and disease-modifying medications early on, so that we identify them early and treat them before they get any complication. Saying so, I do believe that this should be on the primary care level, and that the level model, the care model, should unify primary and other levels in chronic non-communicable diseases, with a possibility of a unified electronic medical record that would enable us long-term follow-up of each person and, of course, effective management and prevention of these complications. So remodeling the care, introducing electronic medical records that are plus minus unified. We didn't discuss European registries, but this is super important. This is what the member states could decide on and do, so that we have an overview of what's happening in Europe directly from unified electronic medical records on the primary care level. And then, of course, finally adding artificial intelligence as another partner in these systems to enable people communicate more easily in between themselves for peer support, as well as with the healthcare professionals.
Nicely said. Maurizio?
Analogy from the document of IDF. At the present time, we are accepting 3 airplane crashes per day for the lack of maintenance. That's obviously a dramatic call to act. On the other side, the last 10-15 years has been never been so promising for both understanding as well as innovative treatment that are not any longer glucose lowering, but also cardiorenal protection, weight reduction dramatically. So there is a lot of opportunity in front of us. Obviously, it seems that there is some immediate change and urgency to act for making sure that this potential opportunity will be fully capitalized.
Okay, thank you all so much. It's been a really great discussion. I hope everyone watching has enjoyed it too. To everyone watching online, thank you for being with us. This has been an IDF Europe launch event in association with Lilly Diabetics and Euractiv as media partner. Take care and bye-bye.